post-thrombotic syndrome. This is actually the only two reasons why treat DVT. Prevent pulmonary embolism, you can do it with something else. You can put a filter, you anticoagulate the patient, or to minimize the risk of recurrent venous thrombosis, you can do it also with anticoagulation. So we treat invasively DVT or with anticoagulation only to prevent a post-thrombotic syndrome. And if we look to the guidelines of the European Society, which is published in 2021, and thrombus removal was mentioned only here. So if you have a patient who has a DVT, the first thing you do, according to the European Society guidelines, you evaluate the risk of bleeding. So is the patient at a high risk of bleeding, or he has no risk of high bleeding? So if the patient has a low risk for bleeding, you may consider early thrombus removal. This is what the guidelines say. So this recommendation has a class 2A and level A recommendation. And the European Society gave this recommendation based on multiple papers, and this is Gary Sylvian Sedemol, Cabin study and the ATTRACT study. And the European Society did a pooled analysis of the data of all these papers, and they found that the risk ratio for any post-thrombotic syndrome was lower with early thrombus removal technique compared with anticoagulation alone. The risk ratio for moderate to severe post-thrombotic syndrome was also lower with early thrombus removal technique compared with only anticoagulation. But the risk for major bleeding was higher with early thrombus removal compared with anticoagulation alone. So based on this result, they gave that recommendation that first of all, you evaluate the patient if he's at a high risk of bleeding. So what we know today, we know that the amount of residual thrombus after successful catheter-directed thrombolysis for iliofemoral deep venous thrombosis correlate with the recurrence. So it means the more we remove thrombus, the less recurrent DVT we will have. So if you have more than 50% residual thrombosis, the recurrent DVT you have a chance of having a recurrent DVT approximately of 38%. And if you have less than 50%, the recurrent DVT will be around 5%. So in 2020, a meta-analysis was published and they looked into the endovascular mechanical thrombectomy versus thrombolysis in patients with iliofemoral deep vein thrombosis. So they did a systemic review and a meta-analysis, and they collected all the trials published between 2001 to 2019, and they looked for the incidence of post-thrombotic syndrome, valvular reflex, recurrent DVT, and as well the bleeding. And they found the conclusion in patients with iliofemoral DVT, percutaneous mechanical thrombectomy was associated with a higher cumulative 6-month primary vacancy and a lower incidence of major bleeding compared with the thrombolysis alone. In these studies, these are the devices which were used to treat the iliofemoral DVT, the angiojet from Boston Scientific. You can use the lytic therapy optional through power plus spray. Then you have the trellis where you have to use a thrombolytic, and you have two devices which are pure mechanical thrombectomy devices. This is the Penumbra device and the Asparagus device. If we look to the Asparagus device, so this is a pure mechanical, so you cannot use thrombolysis through it or additional to it. So it has a big side window and a spiral which rotates very fast. The side window is an H shape, and the spiral rotates very fast, so it sucks the thrombus out. And there is a registry, the Asparagus registry, which is from Lichtenberg. So he did this study, and he included 56 patients in this study, and the majority of these patients were female, and the majority of the patients had a left common pelvic vein occlusion, and the May-Turner syndrome was present in 53% of the patients. So more than half of the patients had a May-Turner syndrome, and 71% of the patients had an acute DVT, iliofemoral DVT. If we look to the result, the primary patency after 12 months was 87%, and the time needed in the ICU or high dependency was almost zero. So 95% of the patients did not require any ICU or high dependency. Now let's look to the low post-thrombotic syndrome. 64% of the patients had a low post-thrombotic syndrome at 1 year, and moderate post-thrombotic syndrome was 36%. No patient had a severe post-thrombotic syndrome. And so they concluded in this registry that mechanical thrombectomy alone without a lysis is safe. Severe post-thrombotic syndrome could be prevented in all patients after 1 year, and low post-thrombotic syndrome was after 1 year in 64% of the patients. The primary patency is 87% at 12 months. So Asparagus thrombectomy device is suited as a standalone approach in the treatment of iliofemoral DVT, and they recommend always to implant a venous stent if a pathology was found. This is how the Asparagus catheter works. You can see here there is a rotational, it rotates very fast, and it sucks the thrombus through the side window of the catheter. The next device where we can use it only without the thrombolysis is the Penumbra device. This is a whole catheter. Usually we use the 8 French catheter, and there was a study about this catheter to see the effectivity of this catheter, and they evaluated the safety and efficiency of percutaneous treatment for proximal deep vein thrombosis, and they evaluated the primary technical success rate and the restoration of blood flow. And they looked into the secondary success rate. So after 1 year, the primary technical success was 77%, 88% patients did not have any recurrence DVT, and they concluded that percutaneous mechanical thrombectomy of proximal lower extremity in a single session using only aspiration thrombectomy is safe and effective in treatment of symptomatic deep vein thrombosis and has a high technical success rate and low recurrence rate. So Penumbra introduced this device recently. They increased the size of the catheter. It's a 12 French, and so you can have a more suction power, but they added as well a sensor to monitor the flow inside the catheter, because when you add the diameter, when you increase the diameter of the catheter, the blood loss will become more. So they added this sensor, so when you are in the free lumen, the suction will become intermittent and continuous, and we have tried this catheter already, and you can see here a patient with a DVT, and we did the aspiration thrombectomy. There was an underlying May-Turner syndrome, and this was stented and correctly aspirated. After 2 months, the patient came, and we did a follow-up, and you can see high success rate, no recurrent DVT. So based on all this, we think today that mechanical thrombectomy is safe. It has a technical success rate. It can be as a standalone, single-session device, and catheter-directed thrombolysis should be used only as a bailout and only after risk analysis for bleeding. Thank you very much for your attention.